A very good evening to you. I am Lisa Lord, and on this one-on-one, we will focus on the work of the Hope Foundation. My first special guest is the president of that foundation, Miss Shelley Weir. Miss Weir, thank you so much for joining us on the program.
Good evening, Lisa, and thank you very much for having us.
It is my pleasure. It's been a long time coming.
Really?
It has been.
Yeah.
But that's a discussion for another time. Now, the Hope Foundation is focused on raising awareness about chronic diseases like lupus, sickle cell anemia, and arthritis. You founded the foundation back in 1991 after your own diagnosis with lupus. Take me back to that time. What did that diagnosis mean at that time? What was happening with you?
So if I have to tell my old story again, in 1990, over 3 months, I got intensely ill, and everybody was wondering what was happening. Eventually, it turned out to be lupus. It was diagnosed as gastro, of the flu, of all kind of things. At the time, I was 28, so any of your viewers want to calculate 1990, 28, I mean, 2023, I celebrated my 60th birthday last year. So at that point, they told me that I probably, when it came to the diagnosis of lupus, they said I probably would not live past that week without getting on medication.
What was that shock like? Because it had to be a shock.
It was a shock because I did not know anything about lupus until I was being told that until I was being diagnosed with lupus. But it was more a relief because then I had an answer to 3 months of being intensely ill, not knowing what to do, going to the doctor all the time, and it was kind of a relief. And it gave me something to work towards because my eventual thing was I want to live, and I don't just want to live. I want to live a quality life that extended into, I don't want anybody else to have to go through what I had been going through in order to get the diagnosis. Because in that time I realized how difficult it was to diagnose. And I wanted to do whatever I could to reduce that.
And that's how we had the birth of the Hope Foundation.
That is how Hope Foundation was born.
So what is the
My
Hope
baby.
Foundation?
So Hope Foundation, again, getting together with family and friends, and I've had an excellent support system throughout my journey with lupus. And it's a good reflection of my life even before lupus. I have good friends, family, and I believe in good relationships. And that is the epitome of Hope Foundation. So I talk to them. This is what I would like to do. This is how I think we can help. We ain't got no money, but we got to do something. And everybody came on board, and that is what we did. But in trying to do that, we realized that there were some other conditions that suffered the same fate that the healthcare system just was not interested in. So we tend to focus a lot on conditions that affect thousands and hundreds, but like Hope Foundation was said to be rare, sickle cell, not that many people. And again, arthritis would have been a good fit for us. So Hope Foundation, as a mission, was that we would concentrate on the lesser known chronic diseases, the ones that did not already have an existing support mechanism, the ones that were being ignored by the healthcare system.
Right, so that was 1991. 32 years later, where are we in terms of public awareness when it comes to these conditions?
I think we have done extremely well over those 30 years. I mean, we had the late Professor George Nicholson, who was a stalwart. I believed in him. He believed in what I was doing, was very supportive in terms of where lupus should go and the kind of attention it should be given. who evolved Dr. Flower, the lone rheumatologist in Barbados, and she still is. And though people may be diagnosed with lupus nowadays, and they see a lot of systems in place, they were not always there. We had to fight for those. And that reminds me that only this last year, actually in November, I addressed the American College of Rheumatology Convergence, and the topic for that was fighting for ourselves. And it made me examine how Hope Foundation was able to survive in a situation where people are only, the system is really interested in conditions that affect large number of people. Healthy lifestyle, how you eat, if you exercise,
The
and so on.
NCDs.
Lupus is an NCD as well. And I could exercise as much as I like. The other person out there could exercise as much as they like, but if they're to get lupus, they can get lupus. Same thing with arthritis, and sickle cell is a hereditary disease. We have had no choice in the condition that we have gotten, and I would say that we should not be discriminated against because of our lot in life.
Do you feel as though persons with these conditions are discriminated against?
By the system, not by people, like not by friends and family and so
When you
on.
say by the system, explain.
Again, it goes back to what I'm saying, where the emphasis is always around numbers. So it's always a number game. So it seems to me too that over the years, every administration that comes into play, every new minister of health we get, we have to legitimize the work of Hope, what we do. And the value of the work that we do seems not to be taken into consideration. And I really think that it is time. We are at that stage in our development where if we want to make a difference in our healthcare delivery and how we treat our citizens, stop looking at the numbers and look at the impact of the work that we are doing.
Let's talk about access to treatment in that regard.
Mm-hmm.
Do these patients have proper access to treatment?
Because of Dr. Flower, I would say, and having established that lupus outpatients clinic, because you would find that the majority of persons are not well off and they need that within the hospital. So if we go back again to the 90s when Hope was, well, when I first noticed, so because of my own situation, Professor Nicholson is the person who was seeing lupus patients, and he was a nephrologist. So they were being seen through his clinic for kidneys. But now, lupus patients have their own outpatients clinic, and there are medications, there are a lot of systems that have been put in place for lupus patients because of what we've been able to highlight in terms of the awareness and the needs.
Is it expensive to treat these
It
conditions?
can be, because, well, a couple of years ago, what we were able to say is that lupus was the 5th highest reason for dialysis in Queen Elizabeth Hospital.
That has changed?
I don't know, I've not looked at the research recently, but that again, I don't know if I could jump into why we did the lupus kits, but that was one of the reasons why we did that.
If I could just focus on the numbers for now, are you seeing more persons being diagnosed with these conditions than 30 years ago?
To put it simply, a study was done that proved that Barbados has the 2nd highest incidence of lupus in the world. We come second only to Italy. Well, let me say reported cases, and a lot of that has to do with the fact that we have been good. And again, I give Dr. Flower credit for gathering information and doing that kind of research. So today we can say we have over 300 patients with lupus, And we know that 25 new patients will be diagnosed every year.
Is that worrying?
I cannot say it is worrying. I'm saying it is a lucky draw because there is nothing that can prevent you from getting lupus. So if I said it was worrying, it would really be to distress that next person who's diagnosed with lupus.
But when somebody is diagnosed with lupus, sickle cell, arthritis, how does the foundation reach that person? Do you have a register in terms of, because you did mention numbers for lupus specifically just now, but do you have a register in terms of reaching out to these persons, offering them support, etc.?
So the activities that we have done over the years that have allowed us to have a pretty comprehensive register. So over the years, almost from inception, we've been doing a seminar for newly diagnosed lupus patients. And until COVID came, we did that annually. So patients would come, and that was one of the ways so that we were able to understand what a problem lupus actually was in Barbados, because this seminar would be one where we invite patients, we invite the doctors who would normally be seeing these patients and diagnosing them. And we would have asked patients, okay, who here have lupus? Put the hands in the air. And the doctors would say, but I diagnosed so-and-so, so-and-so, and they aren't here today. So when we were saying back in the early 90s, we were only diagnosing 8 patients per year. That seminar educated us a little better that there were a lot more than we, by maybe 100% more than we thought we were diagnosing.
Yeah, because you've gone from 8 a year to 25 on
Exactly.
average.
Yeah.
So that is a significant jump. Has any research been done as to why we're seeing this increase?
Again, I don't want to say it is an increase. Perhaps Dr. Flora will be able to answer that a little better. But I would want to go down on his side to say that the level of awareness and the ease in which lupus can now be diagnosed could be responsible for why
You're seeing the
we are
increasing
seeing the numbers that we are seeing. Because remember, lupus was said to be this great mimicker, the great pretender, and it was often misdiagnosed. A lot of times, unless you got the butterfly rash in your face, you weren't even queried for lupus. But only 50% of lupus patients would get that butterfly rash.
And the foundation has a patient advocacy project. Tell me about that.
That is new. That is a new initiative that we are coming with, and this is being funded by a small grant through the Commonwealth Foundation. And we think that patients need to have a voice. We think that there need to be confidence for patients to explain how they're feeling, for healthcare professionals to be effective in their communication with patients. There are a number of threads that we want to pull in this patient advocacy project. So it will do with research through focus groups, surveys, and so on. And it is not just lupus, it is patients. So we are actually asking persons who think they have a story to tell if they want to have a say in how they are treated as patients within our environment, that they should call us and participate in this project.
I want to focus on lupus specifically for just a moment. You have, well, when I say you, the foundation has created these lupus essential kits. What are these kits? What do they contain?
Let me first give you the story behind the lupus
Please.
essential
Please.
kit. When COVID hit, sick people were told not to go to the hospital. The hospital is the best friend of a lupus patient. You could almost call it like a second home. I got worried. Dr. Flower got worried. More to the point, we saw that patients were going through complications other than lupus. I don't want to get extreme and say perhaps they were dying from complications other than lupus, but it was alarming, and we wanted to do something that patients could be monitored without going to the hospital and without having their care compromised. So the lupus kit, a discussion between Dr. Flower and I, how could we accomplish this? Having patients monitored without having to come to the hospital unnecessarily. And we came up with the lupus kit. It contains a blood pressure machine, urine strips, and a thermometer. They are distributed here in our office by appointment, only given by the doctor, because it is not a gift. It is a tool. So patients are invited in to receive the kit. They are shown how to use the kit, and then they are put onto an electronic monitoring record, which is on a portal on our website, confidential portal. And they are shown how, when they take the blood pressure, when they do the urine test, if they feel they're not feeling well and they take the temperature, how they can register those results on the portal. Dr. Flower and select people can look at those results at any time. It's online. And if there are any red flags, they are pulled in to be treated. The patients also know that they do not have to wait. They know, as usual, if they're not feeling well, call the doctor. But at least in this way, we are able to monitor a little better. And the other part of that is good is the education of the patients. Because no longer would a patient tell you, the doctor say you got high blood pressure. They now know what a good pressure is.
Your range, yeah.
Yeah. And there are a lot of other fringe benefits that we have seen coming out from the Lupus Essential Kit as well. For example, when we see somebody is not inputting their numbers into the record, something could happen. When you call them, it could be that they're going through a psychotic period. It could be that they're going through a depressed period. You know, there are a whole lot of things that we are picking up because of these Lupus Essential Kits.
So, in a nutshell, COVID-19, which triggered the creation of these kits, was a very scary time for persons, especially with sickle cell anemia and lupus.
Particularly with lupus, because I began to feel that lupus was really being targeted. Because don't forget that when COVID was first talked about, there was a president in the USA that said if you take hydroxychloroquine, you will not get lupus. Hydroxychloroquine is a life-saving drug for lupus. That created a shortage worldwide. And when you want to talk about advocacy, that is where we had to jump on board to secure the supplies for our patients. Because we even had people here and doctors here who were prescribing hydroxychloroquine to people so that they supposedly would not get COVID. So we tried to ensure that we would not have that shortage of a life-saving drug for our lupus patients.
And it obviously put pressure on your foundation as well, because you weren't able to have your fundraising events.
We couldn't do fundraising. Within COVID and all the protocols that came about, health NGOs like Hope Foundation did not have a category. So when there were all the lockdowns and all that, sometimes myself and other NGO persons used to have to ask each other, are we able to go out today? And, so I would hope that if something like this happens again, that we would at least be consulted and to understand that the most vulnerable people should be involved in the policies that you're going to put in place to manage situations like that. So for example, when we had the COVID vaccination, it was through, sorry for calling her name so often, Dr. Flower and her colleagues, because the patients were calling all the time, Shelley, you take this vaccine? Why? I don't know if to take them or not. If you want to take it, I ain't taking it. I got calls from throughout the region. If you take the vaccine, we got together with the rheumatologists and the regional colleagues. How do we say to patients whether to take the COVID vaccine or not? We did our own survey among our patients to see who had taken the vaccine. If not, why not? Do you want to? And we had to do our own education, and we actually had to put an arrangement in place that those persons who want to get a vaccine, it was accessible to them. And it was an area, a sore spot for me, because one of the first things that you were hearing with the vaccine, the most vulnerable people should be given the vaccine, the people with comorbidities, pre-existing conditions.
Correct.
All of those terms were being flashed about the place, but practically they weren't coming down to the people who they should have been affected.
You mentioned the psychology of a lot of these patients. Is that aspect being attended to?
No. I should explain.
Of course.
Okay. For the ACD, if from the time I was diagnosed with lupus, and the message that we spread in hope, if you're diagnosed early and managed well, then you should live as long as anybody. Therefore, a big part of that is coping. Unless you have an organization like Hope, and it's putting extreme pressure on an organization like Hope to provide all of that coping. And I want to make the point that not every patient who has lupus will want to come to Hope Foundation. Some patients do not want to identify with the condition. Some people think if you come to a support group, it's a pretty pity party. So I am thinking that coping should be part of the mainstream treatment. In our system, the public system, which is where most people should really focus should be, we have psychiatric service that is available, but we do not have psychological services which should help with the coping aspect of these ACDs.
And in mentioning coping, in terms of pain management, all three of these conditions that you advocate for, pain is a factor. Do we understand pain management?
I am not satisfied that we do. I think a lot of people try to look at you and decide how much pain you are in. So for me, that gonna make up my face when I come out and try to look good, so that nobody would look at me and say, well, I feel real sorry for Shelley. She got lupus and Kadir, wrong person. Okay? But because my face is made up, because I'm trying to uplift my spirits and myself, does not mean that I'm not in pain and that it should not be addressed. As a patient, I want to be believed and I want my issues addressed.
Are you saying that in a lot of instances that is happening, where patients are saying they're in pain but they're not believed?
It is certainly a complaint for the sicklers, and as Hope is an umbrella for sickle cell, that would be a concern of ours.
After 30 years, what is your biggest concern?
That we have to legitimize our existence too often. It is always, let me put this as simply as I can. We distribute the lupus kits, right? I think that government has a responsibility to ensure that we exist. And I want to say that we make a difference in the lives of people. We make a contribution to healthcare delivery in Barbados. For example, the lupus kit we talk about, the cost of that is about $200 estimated. It saves persons from needing dialysis treatment, which is $48,000 per year per patient. So I do not understand when somebody may ask, but what do organizations like those do? My question to you is, would you prefer that when these kits are delivered, I do them from my home? And I would say to you, no. I think that government should feel a sense of responsibility to ensure that organizations like mine exist. I think they should pay more attention, not so much to the budget, but to the impact of the work that we're doing.
And speaking about the budget, you need money to function.
All the time.
Is funding an issue?
All the time. Because again, numbers matter. So, all right, well, they don't really affect a lot of people. So a lot of funding would not be driven our way. Okay, let me deal just with the numbers, right? Every life is as important as the other person. You might see some funding coming when somebody of means have somebody who's diagnosed with lupus and call on the services of the foundation and say, hey, we should really support them. When somebody who is well known dies from lupus, or, oh yes, we should really help, but we need consistent funding. So when we celebrated our 30th anniversary, we had a very desperate attempt to keep the doors here open. It was called Keeping Hope Alive, 30 for 30. And we begged people, give us $1 for each of the 30 years that we existed. I would like to see that happen every year.
Ms. Weir, after 32 years, is there anything you wish you could have done differently when it comes to the Hope Foundation?
No, only because I think that we have done the best that we could do. I'm also proud of the ways that we have tried to help ourselves. For example, your birthday pledge is one of the initiatives that we came up with to try to get constant funding. We ask people on your birthday to give the gift of giving. No matter how small, even though we like big, you know, we will be happy if people say, you know what, let me give something to Hope. That would help to open up a regular stream of funding for us. We always try to help ourselves. Behind you, you have the Lupus Essentials, which is a guide from management over 30 years of the experience between Dr. Flora and myself. You see a patient and doctor talking on these pages about the misdiagnosis, mismanagement, and the kind of things that you can do in a resource-scarce situation. We try to help ourselves, and we would be so grateful if other people would help us.
And I'm sure that they will step up. Ms. Weir, thank you for staying true to the fight. It has been a long 3 decades, and despite the ups and downs, you have continued to give hope to many suffering with these conditions. Thank you very much.
You're welcome, Lisa.
That was Ms. Shelley Weir, the president of the Hope Foundation. When we return, we take a closer look at the medical conditions themselves. Stay with us.
The Barbados Police Service is a dynamic organization which caters to the needs of all residents by providing excellent customer service within our communities. We are excited to inform you that we are recruiting new members to our ranks and welcome your participation.
We are building the Barbados Police Service within our communities. Are you smart, skillful, motivated, ambitious, reliable, and talented?
Smart to fulfill your life's dream.
Smart to chart career opportunities.
Smart to make a difference.
Smart to pursue economic sustainability.
Smart to enable change.
smart to provide public service.
I say to you today, if you have a love for people, if you enjoy nurturing your communities and taking care of persons, then definitely the Barbados Police Service, of which I am a proud member, is the place for you. So I encourage you, lend us a hand, join us now to help keep Barbados safe.
Come join us, join me in making our country a safer Barbados.
Your place is here in the Barbados Police Service.
Come, join our ranks and chart a career of economic sustainability. Make that difference as an agent of change while providing public service as you fulfill your life's dream.
Hello, I'm Dr. Ingrid Burrows, and I'm going to give you some tips on managing your hypertension. The first thing you should do is to decrease your salt intake. You should keep your salt intake to less than 1 gram a day. This is equivalent to about 1 teaspoon of salt every day. Another thing you should do is to ensure that you're getting enough physical activity. You should aim for 150 minutes of aerobic exercise every week of moderate intensity. For example, brisk walking, light jogging, swimming or running. This equates to half an hour of exercise 5 days a week. You also want to increase your intake of fresh fruits and vegetables. It is advised that you eat 5 servings of fruit and vegetable every day. And the last thing you can do is monitor your blood pressure at home with a digital machine. This is very important as some patients have elevated blood pressures while in the doctor's office while having normal blood pressures at home. This is called white coat hypertension. Also, if you're taking medication for your hypertension and you notice any changes in your blood pressure, you can call your doctor and he or she can adjust your medications to suit. If your readings are too high or too low, you can inform your doctor and he or she can adjust your medications appropriately. I hope these tips have been helpful.
When does a mental health issue become a problem? When should you reach out for help? I'm Chris Hurdle, clinical psychologist and certified life coach. Mental health issues interrupt a person's daily functions. An issue becomes a disorder when a person isn't able to carry out their everyday activities like household duties, personal upkeep and hygiene, or interferes with their ability to function socially, to interact with others inside the household, or interferes with their ability to function on the job or carry out other activities. If a person finds themselves needing to self-isolate, losing touch with reality, or having an impaired ability to think, reason, or function, and if this occurs over a period of days, weeks, or months, then it is time that they reach out for help.
Keep it clean, keep it green.
Barbadians, we invite you to get involved and play your part as we clean and green Barbados. Come into your community with media launches, bulk waste collection exercises, community engagement sessions, and giveaways. Get on board. Let's keep Barbados clean and green.
Beautiful, beautiful Barbados.
Welcome back as we continue our look into the work of the Hope Foundation. We're joined now by the island's lone rheumatologist, Dr. Cindy Flower. Dr. Flower, thank you for joining us on the program. We know that you have your hands quite full at the moment.
Well, thank you, Lisa. It's always a privilege to represent the Hope Foundation.
Indeed. Now, in terms of autoimmune diseases like rheumatoid arthritis and lupus, how serious is the situation regarding these two conditions specifically on the island?
Well, lupus is common in women of childbearing age, and Barbados actually has a high burden of lupus compared to other countries internationally. And rheumatoid arthritis also predominates in women, and women head a lot of households in Barbados. So it is serious and significant, and there are a lot of other competing health issues, so it makes it a challenge for some diseases to get the attention they deserve. So
But I want to give each of those conditions their attention, the attention they deserve. Let's start with lupus. What is it, simply put?
So simply put, lupus is an autoimmune condition. So the body's immune system becomes overactive. Now, your immune system is supposed to be fighting infections, chikungunya, dengue, any sort of germs. But in lupus, the immune system becomes overactive and fails to recognize your tissue as your own. So it can attack almost any tissue in the body. The most common manifestation is arthritis, so it's known as an arthritic condition because it can attack the lining of the joints. But 50% of cases, it attacks the kidney, and that's a very serious complication of SLE. But it can attack the brain, the heart, the liver, any organ, so it's a very serious disease. There is a genetic predisposition, right? So if you have West African genetics, you're predisposed to lupus. But there are environmental triggers, and the environmental triggers are not well defined, so we don't know what to avoid. So it's not preventable. And unlike type 2 diabetes, it's not a lifestyle disease. You cannot eat or exercise your way out of a disease like lupus. So it's challenging for the patients. Now, rheumatoid arthritis is similar. The immune system becomes overactive. The focus of rheumatoid arthritis remains in the joints. So most people will have an isolated joint disease. Some people will get an attack of inflammation in their eyes or in their lungs, but for most cases, it's a joint disease.
Regarding lupus, in terms of the diagnosis, how is a diagnosis made? Well, let's look at the symptoms before we even get to the diagnosis.
Right. So the most common symptom, 85% of people will have joint pain. Now, the characteristic thing about the joint pain is that it's associated with early morning stiffness for half an hour. So you'd feel, like a stiff, rusty robot, as one of my patients describes it, in the morning. And that may get better as the day goes on. It's associated with a lot of fatigue and maybe fever, swollen glands in the neck, that sort of thing. Sores in the mouth, hair loss, and rashes. So that's the common way it can present. But sometimes it can present atypically, which is why all doctors have to know about the disease, because sometimes they present in a way that draws the attention of a surgeon, like inflammation in the pancreas. Sometimes, it draws the attention of a neurologist, inflammation in the brain. So that every doctor has to be aware of it. And the easiest way to diagnose lupus is to simply think of it and listen in detail to the patient's symptoms and see if what they describe can fit with lupus.
And there are different types of lupus.
Well, the Barbados, what predominates is the systemic lupus, which is the severe kind, can affect multiple organs. There are some people who have an isolated skin rash called discoid lupus. That rash is significant because it scars quickly. So it can cause what we call alopecia, which is hair loss, but scars on the skin. And very, very rarely, there are some drugs, especially some heart medications, that can cause drug-induced lupus. But once the drug is withdrawn, the features of the disease go away, and that's nothing to worry about. And that's something we hardly see. Most of our cases are the systemic disease.
In terms of treatment for lupus?
Right. So the treatment for lupus, as I said, lupus is an inflamed or a dialed up immune system. So the drugs dial back, turn down the volume on the immune system. And the most common is steroids. Now, steroids have a lot of side effects,
yes,
but steroids save lives. If someone has inflammation in the kidney and you want to begin to reverse it within hours. If someone has inflammation in the brain from lupus and they're going into a coma, the only way you can reverse that within hours is to give a high dose of steroids in the veins. So steroids save lives. The other drugs that patients are used to treat this condition suppress the immune system. So of course, the potential side effect of that is that it predisposes to infection. So we have to manage infection risk in SLE. But there have been advancements in the disease and advancements in the treatment that have allowed people to live longer if they take the medication.
In terms of rheumatoid arthritis, in terms of the treatment?
Right. So rheumatoid arthritis, the treatments have advanced. The number one drug worldwide is a drug called methotrexate, which in high doses is used to treat cancer, but in low doses it's used to treat inflammation in the joints. The good news about that is that it's dirt cheap. It's an old tried and true drug. It's safe in children and it's on the Barbados formulary. So, it's a cheap drug. It can work, in my experience, for 2/3 of people with rheumatoid arthritis. The problem is people that have severe rheumatoid arthritis and fail to respond to methotrexate. Then the newer medications are extremely costly. They can cost thousands of dollars for a 1-month supply, and it's not a course of treatment, it's indefinite treatment. So that's a challenge for the healthcare system in Barbados. It's a challenge for the patients, the cost of modern drugs to treat rheumatoid arthritis.
Are you seeing younger patients being diagnosed with both lupus and rheumatoid arthritis?
No. Lupus predominates in women of childbearing age, and we see it, most of it is for lupus, between the ages of 15 and 44. The most common age range is women in their 20s, and that hasn't changed. For rheumatoid arthritis, though it can affect children and any age, it predominates in people over the age of 50. So it's a different demographic. So if someone presents, say a woman presents with painful swollen joints, if she's over 50, chances are it's rheumatoid arthritis. If she's in her 20s, chances are it's lupus. And there are some laboratory tests that help define one or the other. Help, not always, perfect. And of course, what happens in their clinical course, what else happens to them allows us to make a diagnosis of one or the other.
Are you seeing cases where persons are being diagnosed late?
I think
this is for lupus specifically.
Yeah, there are always going to be cases that are diagnosed late. Some of them have very atypical presentations. So the patients that develop arthritis, rashes, hair loss, kidney problems, the common things, they can be diagnosed early. And I must say our general practitioners are in tune with lupus and think about it. Barbados is very lucky that way, because when you think about it, I see the lupus patients because of referrals. Yeah. So that means general practitioners are picking up these cases and referring the cases. There's one particular challenge. Contrary to public opinion, kidney disease in lupus is silent until the kidney fails. It doesn't matter what your disease is. The only kidney diseases that tend to cause pain would be like an infection in the kidney or kidney stones. Other than that, you're not going to know and have any pain. It doesn't cause back pain, contrary to public, belief, right? Thanks. So that when people don't know they have lupus or when kidney disease is the presenting feature of lupus, invariably by the time people get swelling of the legs or feeling weak, that's a kidney that's failing, and then the treatment for that is a lot harder. It's a lot harder to pull those patients back and get the kidney to recover if they present when they present that late.
When you talk to people that have family members or had family members who had lupus, it seems people are not surviving as they were with the condition.
Severe lupus is potentially lethal. That you can't get around that. There are mild cases of lupus where there's no major organ involvement, lifespan is normal. Once you have major organ involvement, there's potential for death. The major organ involvement most associated with death is kidney disease. Because the kidneys fail, the medication used to treat kidney disease and the disease itself can predispose to infection. And sometimes the kidney disease is so severe, it is refractory to the treatment. So we have treatment, but sometimes it doesn't work. And there's a risk of death. And it's heart-rending, it's tragic, it's young people. And that actually was part of the reason that the Hope Foundation set up the Lupus Kit. The Lupus Kit has a blood pressure machine and a urine test stick for protein, because the earliest way to pick up kidney disease in lupus is finding protein in the urine. So we tell patients, you don't have to wait to go to the doctor. Once a month, you can test your own urine. And guess what? If you're going to develop kidney disease in lupus, it tends to be in the first 3 years of diagnosis. So we tell patients, test your urine at home for the first 3 years, monthly. Once you pick up protein, then you present to us. And that's before the kidney is failing. That's at its time where it's going to be most amenable to treatment. And I must mention the other reason why we see significant lupus patients with shortened lifespan is simply failure to take the medication, a belief that, maybe an alternative medicine would work, or I'm just too young to be burdened by all this medication, it's too much. And we see people stopping the medication and having catastrophic flares of the disease.
I'm glad you mentioned the medication bit. Earlier in the program, I asked Ms. Weir about pain management, which she says seems to be still misunderstood.
Right.
A few years back, we would hear about sickle cell sufferers specifically. I don't want to say overdosing, but they were overdoing it with the painkillers, but that's the only type of relief they could get. Are you still seeing cases like that?
No, we're actually not seeing that. There was a particular drug, it's called pethidine, it was addictive.
Yes.
And patients did become addicted and had a craving for this medication. But now there's better treatment for sickle cell disease. Now there are drugs to treat pethidine addiction. So we have a specialist at the hospital. I don't know if you care for me to mention his name, Dr. Mosley III. He helped wean pethidine addicts off the pethidine. So we're really not seeing that anymore. The number one thing with pain on the whole is to delve down into why is the patient having the pain. So if a patient from whatever disease, say rheumatoid arthritis, if they're having pain from inflammation in the joints, there are drugs to treat inflammation and put the disease in remission. If someone is having pain because a joint is damaged and it's damaged beyond repair, they need a joint replacement. If someone is having pain because that they're under stress, unhappy work life or home life, and that gives pain, then they need psychological counseling. If someone is having a lot of pain because they're not sleeping well at night, they need a sleep aid. So it's always about delving down into what is the cause of the pain and addressing that cause.
Now, we mentioned sickle cell anemia. I know you're not a hematologist, but if you could just touch on what sickle cell anemia is.
So it's really a genetic disorder where it's the abnormalities in something called hemoglobin. Hemoglobin is what gives our red cells their color, and what gives our red cells their oxygen carrying capacity. And in sickle cell disease, there's an abnormality of the shape. So they clump together and can obstruct the vessels, and that can cause a lot of bone pain, but it can also have other serious complications. It can cause heart disease and stroke and lung disease.
Regarding rheumatoid arthritis specifically, I've been having these joint pains, muscle pains for a while. People are saying, man, you're just lazy, you need to work out. How do I differentiate between needing to go to see the doctor and maybe just a regular muscle pain or joint pain?
Right. So for rheumatoid arthritis, it's a different type of pain. It's severe pain and stiffness, especially in the early morning, right? And the stiffness can go on for hours. And that tends to get better as the day progresses. Whereas the pain of, say, osteoarthritis or damage to a joint, that will get worse with use of the joint. And rheumatoid arthritis, because there's inflammation, it's associated with fatigue. So people can, feel unwell. But it all comes down to your trusted general practitioner. You present to your general practitioner and they listen to your story, they examine you. In rheumatoid arthritis, the joints may be warm, tender to touch, swollen, soft tissue swelling, fluid on the joints. We can actually take fluid out of a joint and look at it and see that it has inflammation in it. So the doctor has an essential role and mandate to make the diagnosis. And that is supported by some investigations, but the investigations do not always make the diagnosis. It really comes down to the story the patient tells and their physical examination.
With more conditions like lupus and rheumatoid arthritis being diagnosed, you're the lone rheumatologist on the island. I know you must be overwhelmed without question. Why aren't more of your colleagues going into the area of rheumatology?
Well, actually, there are people going over to USA, Canada, and studying rheumatology. Our doctors are well trained and they're brilliant. They get awards when they're overseas and they're headhunted to work overseas. But I would like more people to come back. And there is a need. Not only do I want someone to talk to, patients need choice. And the other thing is, I think getting general practitioners interested in rheumatology. So I belong to an association called the Caribbean Association for Rheumatology, and we actually hold conferences for medical practitioners to educate them on diseases like this. The whole reason for the book Lupus Essentials, and we're also working on a book on rheumatoid arthritis. The whole point of that is to educate general practitioners so that they can help in the diagnosis and management of these rheumatic conditions.
And I know that you work very closely with Miss Weir. It's not very often you see a doctor working so closely with an NGO. So I know that you're pleased with the work of the Hope Foundation.
Yes, and of course, when someone is trained in rheumatology, they'll come and join us as be part of the medical advisory committee for the Hope Foundation, because in a consultation setting, there's a time limit. So we can do a lot with patient education through an NGO. We have seminars for newly diagnosed patients with lupus and rheumatoid arthritis, and we can bring in other people they're interested in hearing from, like dietitians and physiotherapists, psychologists. So it's a fertile ground to educate the people and support the work of the Queen Elizabeth Hospital.
What is your greatest concern regarding these autoimmune conditions?
I want to see better patient outcome, but getting better patient outcome is challenging. It's not only having all the medications you need, some of them are expensive. It's also people are not just their disease, they have lives and they have other responsibilities. So they have a work life, a family life. Some people with diseases are caretakers for other people. So that sometimes they deny themselves to serve others, so they need more support. And other times they need to be taught resilience so that they could meet the adversity of their disease. So that's what I'd like to see.
Well, Dr. Flower, thank you. It was good seeing you. Thank you for chatting with us
Pleasure
this
being
evening.
here.
Thank you.
Thank you.
That was Dr. Sydney Flower, a rheumatologist, the island's lone rheumatologist, as we looked at the work of the Hope Foundation on this one-on-one. I'm Lisa Lord. Do have yourself a wonderful evening.